This is a clinical audit I performed as a Foundation Year 2 trainee at Woolstone Medical Centre in March 2011, when physical activity was very topical in London, just prior to the 2012 London Olympic Games. I started off by discussing the evolution of man from essentially another species into a hunter and gatherer Homo sapiens, which initially involved a very physically active lifestyle and heavy physical activity. The drawbacks were that there was much undernutrition, and as society progressed, other problems such as sanitation and water hygiene became new problems. Many people also cooked indoors, leading to problems with smoke inhalation and indoor air pollution. So, if we look at this graph here demonstrating risk size against time increasing this way, considering traditional risks such as undernutrition, indoor air pollution, water, sanitation and hygiene, over time recently this has come down and these are now relatively low risks. So the evolution of man continued, and we've acquired jobs that involved using tools, and our risks have changed where this industrial work was associated with new outdoor or general air pollution, work associated risk or occupational hazards, and things related to cars such as motor vehicle accidents. So we then continued to evolve to now a much more sedentary lifestyle or occupation. So we then developed these modern risks, i.e. things like urban air quality, road traffic safety, and occupational risks which were low in the past, where traditional risks were the highest risk size. They then increased and then plateaued and now are beginning to increasingly tail off. However, with a further evolution or change, the modern risks have now become risks from tobacco, physical inactivity, and being overweight. So a mock cartoon of the evolution picture has been more recently depicted as this. So how can we look at risks in relation to this, where there are risks which are more difficult to modify, such as age, educational attainment, and income? Then there are these potentially modifiable risks such as physical activity, diet and fat intake or alcohol intake, weight control, and smoking. And there are diseases such as type 2 diabetes, cholesterol, and blood pressure or hypertension. In terms of deaths associated to those leading risk factors, if we look at a graph or a chart demonstrating risk factors such as high blood pressure, tobacco use, etc., as we go down, against mortality in thousands out of a total of almost 60 million people, and then divide these risks by high income here in dark blue, middle income in the lighter blue, and low income in this lighter color, we can see that hypertension is now a leading cause of mortality in most countries, and low-income countries still have things like undernutrition in childhood as a problem and so on, but essentially in the high-income countries and in places like London it's hypertension, tobacco, high glucose and physical inactivity and being overweight and obese and things associated with it such as cholesterol, which are the leading causes of mortality. So if we just look at those high-income countries alone, the top 6 or even 7, the risk factors are those that we've described so far. So let's think about this in a little bit more detail. Physical inactivity. It's associated with 21 to 25% of breast and colon cancers. It has a high association with type 2 diabetes and ischemic heart disease. There is a strong association with mental health disorders, and it's also associated with musculoskeletal disorders such as back pain. Let's look at some studies now. So if we look at here at attributable fractions for all-cause deaths in some 41,000 men and 12 to 13,000 women in an aerobic center longitudinal study, here we have men with the black bars and women in the white bars in terms of fractions of attributable deaths, and here on the x-axis we have low cardiorespiratory function versus obesity, smoking, high blood pressure, high cholesterol, and diabetes. We can see that although obesity on its own is a risk factor, a low cardiorespiratory function is a much greater risk factor for death for whatever reason the cardiorespiratory function is low. So this is not new. If we look at a quote from Hippocrates from 5th century before Christ, he said that eating alone will not keep a man well, he must also take exercise. For food and exercise work together to produce health. And a more recent study, the diabetes prevention program with over 3,000 participants who were overweight and pre-diabetic in 27 centers in the USA, were grouped into exercise, 150 minutes, diet change, and a target of losing 7% of body weight through those means, versus metformin and placebo labeled as metformin. If we now look at risk reduction versus comparing lifestyle versus metformin, lifestyle risk factor reduces risk reduction by 58%, whereas metformin was only successful in 31%. I'm not sure if the study looked at combining both preventions together. In terms of meeting recommendations for exercise, as in that diabetes prevention program, approximately 32% of men and 21% of women met it in 1997, and this has increased to 40 and 28% for men and women respectively in 2009. In terms of age, if we look at the percentage of people who meet the recommendation and the increasing age there, this number declines with age, and by the time you're 75 and over, only 8% of men and 3% of women meet the minimum requirement or recommendation. So looking now at the Lewisham population, i.e. the population that the practice serves, let's have a look at the non-modifiable risk factors such as social group. So if we then compare it to England and the rest of London, Lewisham has a greater proportion of people who are either almost most deprived or most deprived as a percentage of all residents. And if we then look at some factors such as smoking, binge drinking, healthy eating, physical activity, and obesity, we can then look at things where Lewisham is compared to England, which can be significantly worse, not significantly different, better, or not possible to calculate. Unfortunately, Lewisham has a significantly worse smoking rate than the rest of England, but there is less binge drinking and no significant difference for healthy eating or activity, and there are relatively fewer obese adults. In terms of factors like smoking and pregnancy, again, Lewisham is doing better for breastfeeding, but there is concern that it's significantly worse than the rest of England for physical activity, and almost significantly worse for childhood obesity, also significantly worse for childhood decay, the tooth decay. I just wonder how some of these numbers are skewed by the fact that it has a significantly or vastly significantly worse rates of teenage pregnancy. So looking at all age, all cause mortality over the last decade, or for this decade in particular, if we look at men in England and men in Lewisham here in triangles, Lewisham has a higher rate of mortality per 100,000 population, and likewise for women there is also a higher mortality rate overall. In terms of looking at early deaths from heart disease and stroke, again Lewisham has a consistently higher rate of mortality, likewise deaths from cancer. So now let's consider the General Practice Physical Activity Questionnaire. It has been developed to determine if an adult is physically active or inactive or somewhere in between. Essentially, it's a questionnaire which involves asking somebody how much physical exercise and or cycling they do in a week, and then plotting it against their occupation. So a sedentary occupation, an occupation that involves standing, physical work or heavy manual work. So if someone takes no exercise and has a desk job, they're by definition inactive. If someone does heavy manual work but takes no exercise in their spare time, they are active. And then we have the grading in between. Of note, they point out that walking, gardening and housework do not count as physical activity, and ages are covered from 16 to 75 years of age. So the recommendation is that the level of physical activity should be entered on the clinical record for all patients over the age of 16 and should be updated at least every 5 years. We have reviewed this for Woolstone, and there is still a number of patients where this has not been recorded or updated. In terms of the levels of physical activity, we have a number there for men and women graded as either inactive, moderate or active. From the men that were interviewed, 36 were inactive, 10 were moderately active and 7 were active. Similar trend is demonstrated for women, again with the majority being inactive, some moderately active and some active. In terms of the correlation between the recorded and actual physical activity at the time of questionnaire, using the GPPAQ form, where we would label somebody as active, moderately active or inactive, against the current record where patients were graded as avoids or impossible to perform exercise, light, moderate or active. I did a scatter graph where records correlate. If someone is avoids or impossible, they are essentially inactive, so that was the correlation there. But from those who on record were recorded as this, in fact some were moderately or more active. From those who were recorded as performing light activity, in fact the vast majority were inactive. From those recorded as doing moderate activity, most were inactive, but some were more active than predicted. And from those who were recorded as active, in fact 2 out of the 5 were inactive and 3 were considered to be active. So those with coronary heart disease risk of greater than 30%, so that's another calculation, over 10 years, the questionnaire should be completed annually. And I've just mentioned here the number needed to treat versus number not needed to treat. So let's come back to this coronary heart disease risk of more than 30% and activity assessment in the past year. So is it up to date? In 11 out of 46% of patients with this risk were up to date, a number were not known, and where it should be completed every year, the mean number of years where it was completed was 5.8. Then the advice or guideline states that the practice should provide written information about the benefits of activity and the local opportunities to be active. When questioned about this, I asked if patients wanted information about the opportunities, to put number versus want and do not want. Most patients, in fact, do not want to have further information about the opportunities, but some do want it. Then the next recommendation was that when providing physical activity advice, primary care practitioners should take into account the individual's needs, preferences and circumstances. Where appropriate, offer a referral into a condition-specific or exercise and referral program if there are available locally. Then follow them up at appropriate intervals over a 3 to 6 month period. So in terms of what's available in the run-up to the Olympic Games, on what was recommended, there was a systematic review of evidence base for developing physical activity and health legacy from the Olympic and Paralympic Games. There was a campaign called Go London 2012 Health Legacy, stating recent research puts the potential cost of physical inactivity for the NHS in London at over £105 million every year. In the run-up to the 2012 Games, NHS London has decided to take action to get Londoners living healthier, to create a lasting health legacy for the capital. There was this Change for Life campaign, eat well, move more, live longer. And the thing to be aware of is that these things have costs either to the service provider or the service user. So where you're not referred for exercise, i.e. the case for most people, a gym membership is likely to cost you somewhere between £40 and £80 per month. Being part of a sports team such as a cricket club, again similarly £40 to £80 per month. Other sports like football or basketball, perhaps £20 to £40 per month. There are alternatives. They have set up cycle highways all around the same time, but there are difficulties with that, not least being that your bicycle is likely to be stolen. There are risks of accidents on the road, and when you do finally arrive at work, it's probably unlikely you'll be getting change in this sort of facility, and more likely it would be a toilet somewhere in the building that you work in. And the guidelines don't particularly address those over the age of 75, i.e. an increasingly growing population. The guidelines are also not clear for children, where there is significant concern of increasing childhood obesity rates. So, in terms of concluding the recommendations, the questionnaire should be added to the exercise grading, as there is currently a discrepancy between the recommended assessment of exercise and the records held. It should be completed at least every 5 years, and perhaps there is a role for stressing the relevance of exercise as recommended, and providing written information on benefits of exercise, local activities and alternative methods of transport again may be helpful. And there is this utility of referring for exercise programs. The Mayor of London has launched Play Sport, again as part of trying to deliver a sporting legacy. So there are some websites which can assist patients in finding active places. There are local websites which again suggest where people may find opportunities to take part in exercise, and then there are the more generic websites and local sports clubs. And in conclusion, so going back to the original slides of evolutions, we've probably forgotten the relevance of physical activity in a day-to-day basis, and perhaps we just need to remember that a little bit more. But overall, the expectation is we'll continue to become increasingly physically inactive, and it's down to us individually to be in charge of our own levels of physical activity.